Hi, and welcome to week 7 of 8 Beats to Better Outcomes. We are nearly there. This week is all about conservative measures, what should be used and in what circumstances. This is another change that we have been discussing for some time now, but the new guidance really supports us with it. So, why is there a change? Well, previously, conservative measures have been suggested and used as a one-size-fits-all approach. We work our way through a list without tailoring it to the individual circumstances. Our Fresh Eyes stickers and our guidance have encouraged this, not prompting us to think about the cause we are trying to treat, but just recognising a suspicious or pathological CTG that needs action. The 2017 NICE guidance did state that if there are concerns about the baby's well-being, be aware of the possible underlying causes and start one or more conservative measures based on an assessment of the most likely cause. However, this was not originally well written into the trust guidance, probably by me, and the same conservative measures were being used in all cases of suspicious and pathological CTGs. The new NICE guideline contains the same statement, but adds to it further when considering which conservative measures are and aren't appropriate in which situations. So let's start with IV fluids. What's the problem? IV fluids have been a go-to for midwives and obstetricians for any and all CTG changes. However, do they actually help? If the baby has a prolonged deceleration and the woman is hypotensive, commencing a bag of fluid is a completely appropriate conservative measure, as it should increase the maternal blood pressure and increase the fetal heart. However, if the prolonged deceleration is caused by a cord prolapse, no amount of IV fluid is going to improve the fetal condition. If we do not work to understand the cause of the problem, we not only risk not treating it appropriately, but we also risk causing harm to women and babies by overloading women with IV fluid, which can dangerously alter their electrolyte balance and risk maternal and neonatal seizures. In the context of concerns about a CTG, NICE only now recommends starting IV fluids if the woman is hypotensive or if there is sepsis suspected. So what about maternal position change? Well, as we all know, maternal position can have a significant impact on what we see on a CTG. A supine position can lead to compression of the abdominal aorta and superior vena cava, not only increasing the risk of maternal hypotension and associated prolonged decels, but also decreasing the blood flow to baby, increasing the risk of gradually evolving hypoxia, and showing on the CTG as increasing variable decelerations, rising baseline, and reduced variability. Always consider maternal position alongside the clinical picture when a CTG is deteriorating, and support the woman to change position where appropriate. And what about hyperstimulation? Remember, anything that is happening to the uterus has the potential to impact the baby. During a contraction, there is a temporary interruption to normal placental perfusion, where a baby cannot oxygenate itself fully. If the baby does not have time to rid itself of built-up CO2 and reoxygenate between contractions when placental perfusion is at its best, because they are coming too quickly or lasting for prolonged periods, the baby will soon show signs of hypoxia. If the connection is not made between CTG changes and hyperstimulation, appropriate action cannot be taken. Where hyperstimulation is recognised, steps must be taken to reduce contraction frequency to allow baby to recover and an ongoing plan to be made. This may be by reducing or stopping an oxytocin infusion or considering giving terbutaline. In summary, the conservative measures we have available to us haven't changed. The change is around recognising what the problem is in order to treat it appropriately, rather than working through a list of interventions that may not only not work, but may also cause harm in themselves or by delaying more appropriate action.